Welcome to the conference session titled Transplantation for Aplastic Anemia, MDS and PNH. Is transplant right for me? Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMDSIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Zohra Nooruddin. Dr. Nooruddin is Assistant Professor of Hematology Oncology at Mays Cancer Center, UT Health San Antonio, and practices at Methodist Hospital. She is board certified in hospice and palliative medicine and in hematology and oncology. Welcome, Dr. Nooruddin.
Thank you, Alice. Thank you so much for the introduction. Good afternoon, everyone. We're going to start with our topic, but before we get to that, I want to thank the Society for organizing this event. For all of us, it's not very helpful, but also helps identify the challenges and the resources in the area. Like Alice said, I'm part of MD Anderson Cancer Center at UT Health San Antonio Mays Cancer Center, which is the only NCI designated center in South Texas. So I'm hoping that if anyone is in the area and wants to come to our center, we welcome you. Let's start with the presentation. And after that, we'll discuss the questions and address any questions that you might have. So the topic today is aplastic anemia, MDS, and PNH. And the question is a transplant right for me? Before we go into this session, I have no disclosures. I would like to give you an overview of what actually is stem cell transplant, or what we call hematopoietic stem cell transplant, or bone marrow transplant. So there are all these different names that have evolved over time. And but both physicians and patients, we use them loosely. There's not much difference, but over the years, science has changed. So now we do try to be a little bit more specific. So this presentation will first cover the concepts of stem cell transplant and then go into detail of each disease, MDS, aplastic anemia, and PNH. We'll discuss the risk and benefit. Since all of these diseases, MDS, aplastic anemia, and PNH, are characterized what we call as bone marrow failure syndrome, the standard of care is a transplant called allogeneic transplant. So the principles that we discussed today will apply to all these three diseases. When we say hematopoietic stem cell transplant, what exactly it is? People are more familiar with respiratory system that consists of lung, or GI system that consists of colon. But we really, I sometimes have, challenges myself also. What is like a blood system, right? Is it only the circulating blood? But the main system lies in the center part of our bones. So all our bones from head to toe, there is a center gooey part, the soft part, which is called the spongy bone. And this is where the blood system originates. And this is what, if you've had one of these diseases, you've had a bone marrow biopsy. So we're actually looking at this part of the bone, which is the factory where the blood system is made. So the spongy part has these stem cells. They're the fountain of youth cells, which multiply and divide, and they do their work, they live their life, and they die. Every day, millions and millions of these cells are made. They differentiate into red blood cells, which give color and oxygen to the body. They differentiate into platelets, which help us from bleeding to death. And then the white blood cells, mostly, that's the topic of today's discussion, they fight infection. This is a slightly more complex schema of the blood system that we talked about. So the process of hematopoiesis starts from this hematopoietic stem cell, which we talked about. Now, the great power of this is, as you can see, it has a self-renewal power. Like one cell can regenerate and make more stem cells. Some organs, as you know, in the body cannot regenerate. But then if you look at the bottom product, and again, it's a little bit simplified into platelets, red blood cells, and all these are white blood cells. So at some point from stem cell to the end product, they become more specialized and more specialized and more specialized to come into one lineage. Like either they will be specialized to become platelets or white blood cells or red blood cells. And how does that process happen? It happens with the help of like hormones and cytokines and interleukins. It's like making a soup or a recipe. You need to add a little bit of fire, you need to add a little bit of spices, you need to add some water, and then you get the final product of the blood cells. And this one also, again, is a little bit simplified. There are more cells and different types of white blood cells that come along the way. So indications of stem cell transplant. In general, when we think of stem cell transplant, or some patients ask, like, is it a surgery? Because we are used to listening to lung transplant, heart transplant. So people also think that stem cell transplant is also a surgery or a major procedure. And what are the indications? So most of us know that we use stem cell transplant for blood cancers like leukemia, lymphoma, myeloma. At some point, 20, 30 years ago, there was a lot of research going and actual transplants happening for breast cancer. Then they found that it was not very helpful. But some other solid cancers like neuroblastoma in kids or testicular germ cell tumor. Now this, I'm giving a general for both types of transplant. There are certain genetic blood disorders like sickle cell patients can get transplants, thalassemia patients can get transplants, which we don't see that much in our country, but these diseases are common in Africa and Asia. And certain autoimmune diseases have a limited role. They're not robust studies going on to support, but they do help in certain cases. So you can see there's a wide variety of diseases other than blood cancers that are indicated, and we use transplant for those. When we talk about transplants, there are two different types of transplants. One is called, so this is our patient, and if she gets her own stem cells, this is part of the transplant. This is a type of called auto. Auto means self, which means you're getting your own stem cells. But if you get a stem cell from a donor, and we have two broad categories of donor. It could be like an adult donor, or it could be cord blood donor. So for adult donor, we have few options. We have a sibling donor, which is a match for you. Then we have match unrelated donor, where we weren't able to find a sibling or people didn't have a brother or sister. So matched, still matched, but unrelated. Nowadays, a common type, which is, I'll show you the numbers, which is increasing, because as you can see, it's difficult to find a sibling who's a donor. So we take haplodonor, which is either your parents or your kids, which share half DNA from you. And then very rarely, in certain conditions, we do use mismatch unrelated donor that has its own risk and benefit. But the two different types are mainly divided into auto and allo. And allo is from someone else, like you need a donor. So some people also use donor stem cell transplant for these diseases that we're talking about. The words like we discussed are allo transplant or hematopoietic stem cell transplant or donor stem cell transplant. So this slide shows the estimated number of annual stem cell allo. We're only going to talk about, eventually we're going to talk about mostly allo, but this slide you can see the number of auto transplants is increasing significantly, and it continues to increase. Same goes for the number of allogeneic transplant. Up until the society CIBMTR, up until 2007, most of the record was voluntary, like people would report, institution centers would report. But it was assumed that the data before 2007 was 90% up to date. But eventually, it was required for all institutions who are doing allogeneic transplant to report their numbers. So now we have an accurate idea for the number of allos, and autologous is still 90% accurate. The point is that these numbers are increasing significantly, which also means the survival is increasing significantly. The care, the pre-transplant outcomes and the post-transplant outcomes are increasing. And you can see the numbers have, from 1992, so from 2000, the numbers have gone to almost 10,000 in the last 2 years. So 5-fold increase in allo and almost 8-fold increase in autologous stem cell transplant. Let's talk about the sources of the donor. We just discussed the donor, what types of different donors are there. And since we're talking about donor, it's called allogeneic stem cell transplant. And these slides are mainly US data. So the orange line is unrelated bone marrow or peripheral blood transplants. The blue line is match related donor. The other relative is the green line, which is haplo that we just talked about. It's not a sibling, but it's either, which could be a sibling also, but haplo, and then unrelated cord blood. So if we look at these different types of transplant, the number of unrelated transplants has surpassed the number of allogeneic transplants from related donors after 2006. And that was when there were a lot of publications about cord blood transplants. But what you'll see, the number of cord blood remains the same, or in the coming years, it will go down as the number of haplo increases. So these are the donors. The availability differs, the indication differs, the patient's general health when we're selecting the donor, HLA mismatch and compatibility. These are the factors where we look for the patient, the disease, and the donor. So we have to look at 3 things when we're selecting. And that is one of the reasons that the cord blood usage is going down and the haplo indications or haplo donors are increasing. And the reason is also by availability of the haplo donors. we've come up with post-transplant care much better for these haplo patients. The striking part of this slide is is representing the age of American population by which they get transplants. And what I want you to focus, because the diseases what we're going to talk about are mainly the disease of above 65 and 40 to 64. And as you can see, what used to be in like single digit numbers, percentage of transplants have now increased to almost 1/4 of the transplant above 65 in 2019. So this is very promising. This tells us that we can take more and more of our older patients to transplant. And this is only because of better transplant, post-transplant care, use of infection control, graft versus host disease strategies, and pre-transplant improvement in disease. And these are the reasons that that we're taking more and more older patients to transplant safely. Okay. This slide talks about selecting the selected disease trends. And as you can see, we're mainly talking about MDS here, but there are some diseases where the transplants have gone down, the number of transplants have gone down, like this green or light green and CLL. And this is because why are there no transplants going on in this disease? This is because we have mastered the disease without needing transplant, with just treatment, chemotherapy treatments or novel treatments. And maybe one day it will happen the same with diseases like AML or aplastic anemia, but we won't need transplants. But as of 2022, the only cure for AML, MDS, and some high-risk diseases is transplant. And you can see MDS and AML remain the top 2 diseases for which people get transplant. So this just gives you an idea how the field has evolved from 2000 to just in like 20, 22 years, the numbers are increasing. Let's just discuss briefly about what does it mean when we're talking about transplant? What are we actually doing, right? When patients are asking what's going on. So first of all, we'll talk about the process, but the 2 broad physiological or therapeutic implications of transplant are, first of all, we are wiping because of the disease marrow. Before we start the transplant, we have to wipe the disease, wipe the marrow from the disease cells. And then when we do transplant, which is just a form of blood transfusion, you're replacing the disease marrow by a healthy marrow, by a donor marrow. We're talking about allogeneic transplant. And then from that marrow or the donor stem cells, we're hoping that those donor stem cells will stay there in the marrow, develop their own stem cell system, and eventually make a whole new blood system. And with that immune system, the benefit also is, because this is a healthy immune system, it also fights the disease. Whatever left of disease is there, even small amount that our eyes cannot see, that's what we call graft versus leukemia effect. So those healthy cells are fighting the leftover disease also. So this is the general principle of the donor stem cell transplant. When we think about, or when we talk about transplant, your hematologist and transplant physician will start thinking about these things. But also, you know, I feel like patients also need to understand what exactly, you know, the doctor is looking for, or why am I not a transplant candidate, or why do I need transplant? And we come across certain activity levels. So there are 2 or 3 different activities where we stratify patients, whether the patient is active or not. And one of the common ones we use is ECOG performance status, or the other one that is more commonly used, and I don't have a slide for that, is Karnofsky performance status. And it's not a very easy decision. The decision to transplant or not to transplant involves a lot of calculations. A lot of it's an art, but it's also an calculated art. So it's not, let's just take this one to transplant and not this one to transplant. So when we think about this, we have to look at patient factors, disease factors, donor factor, and post-transplant care. And one of the important patient factor is performance status. It could be calculated by any scale, ECOG, Karnofsky. The more active you are, the more better the outcome. People in the 3 or 4 category where they cannot take care of themselves, they're confined to bed or chair more than 50% of the times, are most likely not the right candidate. So someone who is, I'm sure not everyone is fully active, but someone who can, fully ambulate and is able to carry light work is a better candidate than a performance status of 3 or 4. Now, there are some other factors that we are, this may be a busy slide, but the other factors are looking at body function. So patient's body function. And this is a very common, like a scoring system. So it's not in the eyes of the beholder. We score every patient and discuss the risk of the complications, treatment-related complications for transplant. And then if it's very high, the risk of transplant is high, and then we decide not to go for transplant. So then when we're assessing the organ system, we're going to look at the major organs. We're going to look at the pulmonary, the lung. We're going to look at the heart function. We're going to look at the liver function, the kidney function, and each will get a point depending on how fit the function is, how good the function is. And based on those scoring system, and there's one more slide to that. So if the patient have other cancers going on, like other than, skin cancer, non-melanoma skin cancer is a very common disease, so that's not excluded. But if you have a history of prior cancer, if you're not in remission, or other cancers, then that's a little bit risky to take you to transplant. So most of the times, for that moment, you're not a candidate for transplant. The other risk factors are diabetes, a stroke, if you have any autoimmune conditions, brain, mental health is very important, history of previous infections or bowel disease. And again, weight is also, BMI of more than 35 gets you 1 point. And at the end of the day, we both these, the whole scoring system, and we calculate the risk and discuss the complication rate with the patient, and then make a mutual decision. This is somewhat summarizing the previous slide. So what are good risk candidates and what are high risk candidates? Young age, very common, right? Young age, you're good risk. If you have no comorbid conditions, if you have no active infections. One of the most important factors is how is your disease prior to transplant? Is your disease controlled? Especially in AML, somewhat in MDS also, you have to control the disease to a better rate. So the transplant has to just clean up the leftover. The other important factor is very good social support. So it takes a city, for the whole patient to go through transplant, post-transplant care, and the survival part. So we take it very seriously about the support system for the patient. And the disease, low risk of post-transplant relapse. So if the disease is better controlled before transplant, the post-transplant relapse rates are low. And high-risk patients are the opposite of the top. If you're old, if you have multiple medical problems, if you have disease that is not controlled, if you have high-risk disease or bad outcome disease, then you're not a good candidate. So common indications that apply for all three transplants, or in fact, all type of allogeneic transplant. This is the summary of the previous slide. Again, there are specific renal function cutoff, there's specific cardiac function cutoff, there's specific pulmonary function cutoff, and it varies slightly from institution to institutions, but overall, most institutions, they follow the same criteria based on the guidelines, based on the score. Now let's talk about what exactly is allogeneic stem cell transplant, right? First, we are collecting the stem cells from the donor, which if it's a cord blood, it's usually stored in a cord blood bank and we get it from there. But if it's a donor, the donor is given growth factor shots. So we make sure all the stem cells come out of the marrow. We talked about the marrow, and they come in peripheral circulation. You put a big catheter in their arm and collect the marrow or stem cells, sorry. So it's not, no one is going through a surgery, no one is going through, in most of the cases, except we'll talk about aplastic anemia and PNH, is slightly different. But most of the stem cell transplants, so the other word now we use is, we call it peripheral blood stem cell transplant. So bone marrow, again, it's not a bone marrow transplant. So again, misnomer. So now we call it peripheral blood stem cell transplant. So this was the donor part, and now we move to the patient part. So once we've collected, the patient will then be admitted, or it happens simultaneously also. And then the patient gets a conditioning regimen based on the disease, based on the risk factor, based on the patient's age. And after the chemotherapy is given, the patient receives the stem cell transplant. And as you can see, the stem cells are given like in a form of, like, it's a bag, like transfusion. It can vary, the numbers can vary from 2 to 3 bags or whatever, how much they've collected. But it's given like a blood transfusion, peripheral blood, mostly through a central line that we get specially for these transfusing stem cells. So no surgery, no sedation, it is a peripheral blood stem cell transfusion. Now we're going to come into specifics of these 3 diseases that we talked about. We're going to talk about. And I want you to understand that all the 3 diseases, they are heterogeneous. There have an MDS, not one MDS is same. There are so many things that come into account when you're making the diagnosis of MDS. Once the diagnosis is made, you have to stratify the patient into different risk groups. And again, risk group and then patient's comorbid conditions. So when we're talking to a patient, we have to look at all these things. The definition, the book definition or the medical definition of MDS is, you need to, I want you to appreciate this slide where you're seeing how the MDS looks. We talked about how all these diseases, they cause low counts. In the blood, you will see low white blood cells, low red blood cells, and low platelets. But look at the marrow, and you'll see the marrow in aplastic anemia. The outside results are different, but the marrow looks different. This marrow looks like these cells, they're more cells, they do look abnormal, but I'll show you when I show you the marrow for aplastic anemia. So definitely you need to have cytopenia. Dysplastic means they're in a good shape, and these are because of the mutations that happened And then the final, when we do special testing, cytogenetics or mutation, you have to make sure they're coming from one abnormal cell line, which we term as clonality. So they have to come from one abnormal clone. And most of the time that clone arrives from the stem cell that we talked about, the top mother function of your cells, and it is passing the abnormal clone to all the cells. Now in MDS, it's mostly the myeloid or the white blood cells or the neutrophils that are affected. It does have a tendency to progress to AML. It is some more common than other diseases like aplastic anemia or PNH. And then the most striking part is the median age. As you can see, we talked about older patients, but the problem with this disease is that the median age is 70. So most of the patients, when they're affected, they are old. So whenever, this is a complicated chart, and it could extend a little bit more, but I want you to understand that when we talk about MDS, this is what we talk about, that this is not one disease. These are the different categories that any patient can be classified. And it doesn't end here. But what I want to say, whenever we diagnose someone with MDS, the goals of care should be discussed at the time of diagnosis between the patient, their loved ones, and the clinician, and reassess periodically through the course of the disease. There should be mutual understanding of the goals of care to decide the optimal therapy and facilitate whether, the patient wishes for aggressive treatment, which is curative, like transplant, or the patient is fine with getting supportive care, focusing more on quality of life. So as soon as the diagnosis is made, that's what I try to do, discuss with the patient, the long term, not what we need to do next, but the whole picture, give them a whole picture. In that picture, you do need to talk about the risk stratification. This is one model called IPSS, which is slightly older. Nowadays, there are newer models. So I'm going to pass the slide and talk about the revised model. So the revised model was designed on like 7,000 patients. And this is very older, so we don't have most of the treatments that we are using now for this model. And that's why now there's another model called molecular revised model. But this is more clinically used up to until now. In future years, it may be modified. This defines MDS on the basis of, you look at a couple of things. Once you've made the bone marrow diagnosis, then you're going to look at the special genes, the mutations, and based on each, if it's good, very good, intermediate, or poor, you get these scores. Number of blasts, which are the bad leukemic cells, and the number of, and the severity of the low counts, like hemoglobin, if it's more than 10, if it's less than 8, and for each you get a score from 0 to 4. And based on the score, it is divided into 5 categories. So the IPSS was divided into 4 categories, but now the revised one is slightly more sophisticated and divided into very low to very high. What I want you to focus for today's session is we're going to talk about high and very high, but I want to appreciate this blue thing. So the median survival for very low MDS is 8.8 years. And unfortunately, for very high disease, it's only 8 months. So if you can appreciate it, all these patients have MDS, but one is very low and with 9-year survival. And you can guess that this patient most likely will not benefit for transplant because the survival is 9 years. But these are the patients where the survival is 8 to 16 months. these are the patients that would be indicated for transplant. And this graph is showing you the survivals. Again, from very low is the blue, which has a good survival, and very high is the green, which has a survival of less than 1 year. And then the other part, the other complication of high-risk MDS, there is a chance for them to transform into overt leukemia. And very high risk has a higher chance, and very low risk most likely don't get transformed into leukemia. So again, that decision, these are the decisions that we look for MDS specifically when we're thinking for transplant for them.
Excuse me, Dr. Nooruddin, and we need to interrupt you for just a minute. We're having a little difficulty with the sound. So we're going to just take a pause and see if we can correct the sound. It's a little intermittent with we're not hearing everything clearly.
Okay, let me try and sit. Is it better now? Is the sound better now?
It's still a little bit intermittent. Is it possible someone else in the home is using the internet? It could be an internet use issue.
No, no one is using internet. I mean, this is the best I have. I don't know. Let me just ask. There are only 2 people in the.
Okay, I was gonna say just now that was a little more clear.
Okay, I'll put my face near the laptop a little bit closer.
That may help. Thank you.
Yeah,
Thank you very much.
I'll move closer to this mics or speaker.
Okay, thank you.
Okay, so how do I go? Can I restart now?
Yes, you are clear to restart.
Okay, sorry about the sound, but I'll try to be more closer to the laptop. So the treatment, we're only going to focus for high-risk MDS, and this is mainly adapted for 2022. If we have a high-risk patient, we know that the transplant preparation, transplant out, can take a few months, 2 to 3 months, sometimes depending on donor availability. So meanwhile, we do start patients with HMA, which is a form of chemotherapy. It can be combined with other agents, sometimes doublets, or now there are clinical trials that are starting with 3 agents to control the disease pre-transplant. And what are they controlling? They're controlling the number of blasts. They're controlling the dysplastic cells. So when you go for transplant, the outcomes are better if the disease is well controlled. And then you talk about the first thing you're going to ask is the patient a candidate for stem cell transplant based on the risk factors and the patient factors that we just discussed? We're going to start looking that if there is a donor availability and the patient is favorable, then take them to stem cell transplant. If the donor the situation is unfavorable, then we have no other option than to continue transplant. Sometimes things improve between this phase and eventually the patient can be taken to transplant. But for high-risk disease, if the patient and the donor availability and all the other factors that we discussed are unfavorable, we have to continue HMA treatment with other agents like we talked about. There are clinical trials going on for 3 drug combinations in high-risk MDS. The other option is always, which I highlight all my patients is to, and I help them look for clinical trials if they have resources to go to other cities or big centers where they have clinical trials for MDS, especially because it's a disease of, we talked about older people, and they're very, very, very unique things about each and every MDS. So not all older patients with MDS have same formula that we can carry and give them treatment.
Excuse me, Dr. Nooruddin, if you could share your screen again when we stopped for the sound issues. We need to do that again for your slides.
Okay, sorry.
That's okay.
This slide shows the survival after stem cell transplant for MDS for patients that are more than 18 years old. I do want you to appreciate that this data is slightly older from till 2018. The outcomes are getting better and better, and I'll show you that in a future slide. But the only potential cure when we're discussing with the patient for MDS about goals of care, transplant has the cure potential. Outcomes do differ based on this disease status. We talked about low risk, high risk disease. And this data is based on almost 7,000 patients who received transplant for low risk and high risk disease. And you can appreciate, so let's look at the blue line first, which is pointing to the low risk disease. And this talks about match related donor and like sibling donor, and this talks about unrelated donor. So the 3-year survival for low risk disease is approximately 50%, 51% if you have a match related donor, and just slightly lower 3-year survival of 44% for low risk disease. But if you have high risk disease, then the survival goes a little bit lower. These are the green dashed line, where the 3-year survival is 46% if you have a match donor, and slightly lower, 43% if you have an unrelated donor. But we'll see there's a silver lining that this is what I was talking about. These are the outcomes or survival trend outcomes from 2001 to 2018. And you can see the 3-year survivals have improved from 38% in 2001 to as high as 48%. We're talking about 3-year survival. So from 38 to 48, 10%. And I can tell you that if we go look at the data for between 2018 and 2022, the survivals have improved more because more medications have come up for controlling graft versus disease and infections, which are the 2 leading causes of mortality in these transplants. We're going to switch gear a little bit and talk about the other 2 diseases, which are not very common, but also the second and third most common cause of bone marrow syndrome, failure syndromes. And this is the marrow on the right is how it looks under the microscope for patients who have aplastic anemia. So you can see there's a lot of this white part, which is hypocellular or acellular, and this is the purplish part is your normal stem cells. Aplastic anemia is actually was defined early 1990 or late 1888. So this is an old disease, and it was fatal at one point, and it would come suddenly, affects young people, and we didn't know what was happening, and the patients would die mysteriously. But now the success rates are amazing, and we'll look at the cure rates for this disease. It's again again, rare. It's in Western countries, it's 2 per million. It's slightly higher than Asian, it's slightly higher in Asian countries. And we talked about how the bone marrow is more fatty bone. And they're different. Again, this is also not one disease. It mainly we can divide into 3 basic principles how someone can get aplastic anemia. And the treatment and the type of transplant differs slightly. The good thing about it is that half of the cases are the patients are young. So at least we have 1+ going on that the patient is mostly young and healthy. The unique part about all these bone marrow failure syndromes are they can coexist with each other. Like aplastic anemia will have a component of PNH or can evolve into AML. So they are very, it's sophisticated, but they can sometimes keep evolving over time. So accurate diagnosis is very important. And this is the schema what we were just talking about. It's mainly categorized into 3 broad causes. And the causes are chemical or physical damage, like through drugs or radiation. The common one is immune destruction, where you're at risk for immune-mediated damage to your stem cells, and that's how you cause this white marrow where all your stem cells are destroyed. And then very, very rarely you'll find these genetic defects. And the reason we need to identify which one is the cause is because in these genetic defects, we need to make sure that the sibling donor also doesn't have the same genetic problems when we are talking about transplants. The general principle is the same for treatment, but some slight variation. This is an extensive list of the same things that we talked about: the drugs, the toxic chemicals, the immune disorder, sometimes viral infections, and there's also like pregnancy can be associated. So it's sometimes important to identify the cause and do some sophisticated testing to identify. The end result will be the same. You see this bone marrow, but then identifying the cause is important. And this is what I was talking about. If you appreciate this aplastic anemia in the orange, it does share certain characteristics, certain genes with MDS, with AML, with LGL, with PNH. These are all the diseases of the stem cell. So this one is a general schema. It's a slightly busy slide, but we'll talk about once you diagnose a patient with a severe aplastic anemia, we start thinking about the age of the patient. Again, age is very important, although it's not defined. It can be 70 or something, but in theory, in aplastic anemia, age is mostly less than 40 or 40 and 60. If you're less than 40 and if you have a related donor, you can go through stem cell transplant or donor stem cell transplant. But sometimes if you don't have a donor and it's taking a while to get the donor, we can start treatment with immunosuppressive treatment and then control the disease, find the donor, and then go for stem cell transplant. The second category is more than 40 to 60. Because we know that the outcomes may not be as good in older patients, so we can start with immunosuppressive treatment. And nowadays, immunosuppressive treatment have been modified so much. We used to use one agent, but now this combination of 3 agents, cyclosporin, ATG, and L-Trombopac, which is a growth factor. So it's like a mixed cocktail, and the outcomes are really good. So we don't necessarily have to transplant the older patients. And again, if they're very, very old or less fit, supportive care can be the only option to treat them, because immunosuppressive can also be a little bit hard for very old patients. So think about when we're talking about anemias, which category do patients fall? Less than 40 fit with a donor, 40 to 60, not very fit, immunosuppressive, and if they are very, very, very frail, then just supportive care could be the best option for them. These are the outcomes for donor transplant for aplastic anemia from 2008 to 18. And this data shows that the survival rate, again, from related, unrelated donor, you can appreciate the difference of 74 to 81% outcomes. The next slide, again, same thing, like the same pattern. I want to show you this pattern where the outcomes are improving from 2000 to 2018 and even more from now. So the outcomes have improved from 66% to 83% in 2018. So the positives of transplant, post-transplant care is here. The few principles of aplastic anemia are that if there is a donor, take them to transplant directly. Marrow, now for both PNH and aplastic anemia, like we talked about the peripheral blood donor, these are the two diseases where we prefer the marrow to be, the cells are directly extracted from the marrow, because in these type of diseases, we don't want a graft versus host or a graft versus leukemia effect. So that's why in these diseases, to decrease the GVHD, a marrow donor is preferred. We're going to briefly talk about PNH. Again, this is even rare than aplastic anemia. Median age is in 30s. This is a complex. Patients have more symptoms than other type of blood disorders, like in leukemia, lymphoma. Patients are not very symptomatic, but this is very unique disease. You'll have a history of thrombosis or a clot, renal failure, and then as the disease indicates, there's hemolysis, which means your blood cells are being destroyed. Also has a strong component of immune component to the disease. This disease is easier to classify. So not like MDS has like 20 categories. This is basically, there's a very silent form, which is subclinical. So most patients don't need any treatment except watchful waiting. So they don't even require medication or anything. The symptomatic one, we're fortunate that now we have two immune therapies approved, eculizumab and revelizumab, that are approved. They're expensive, but they have good outcomes.
Excuse me, Dr. Nooruddin, I'm going to need to interrupt you again. I'm sorry, the sound is very intermittent again. What might help is if you turn off your video, that might affect the signal a bit. And that might help with, we'll still hear you, but you would just turn off the video. We would still see your slides.
Okay. I don't have meeting control. Let me stop sharing first. Sorry, folks, for the sound problem. We're almost done. So PNH with bone marrow failure syndrome is the point where we need to talk about transplant. So again, the transplant that we're going to use is allogeneic transplant, and we talked about, you know, the post-transplant treatment, that for some diseases we also need post-transplant treatment, and in this disease we could use eculizumab. The principles of transplant and PNH, we taught bone marrow versus peripheral stem cell because we don't need to get the complications of GVHD, preferably a match rather than unmatched. And conditioning regimens, the good part is they've done studies, and we didn't talk about much conditioning regimen, but this is the preparatory regimen that you get before transplant. And in PNH, you don't have to give an aggressive or what we call myeloablative regimen. Reduced intensity regimens, like slightly gentler regimens, have the same outcome. Briefly, last 3 slides, I'm going to focus on general complications. This is a very simpler version, but some people can have many more complications. So the first one you can see is the toxicity of the transplant or the conditioning regimen itself. So mucositis, GI toxicity, diarrhea, nausea, vomiting. And of course, we're talking about the blood system. So the low counts, low white blood cells, anemia, thrombocytopenia, low platelets where we're transfusing them. Graft rejection, very rarely, we don't see this very commonly. It's a rare complication where the donor cells are not taken up by the body. It's not a common complication, so we don't worry about it too much. But the most common ones, both in acute setting and in late setting, is graft versus host disease and infectious complications. And these infections can happen in acute setting or chronic setting. Sometimes people can have long-term infections, like even years after transplant, their risk for the immune system the new immune system may be compromised by the use of immunosuppressive drugs. So when we're discussing the complications, these are the complications we focus on for post-transplant discussion. This is the second last slide. We're looking at patients' age, comorbidity, conditioning regimen, support, and the graft versus host disease. During the transplant period, the transplant-related complications, but these things are also very important. The post-transplant course, psychological recovery, your sexual function, you go back to work in your social life. So these are the things when we initially talked about, the physician has to talk about goals of care with the patients, that what are the outcomes if we go for transplant to get this life back, right? Because that's the whole goal. We want to come back to our normal life. And it applies to all kind of transplant for all these 3 different diseases. So the take-home points for today's talk are, we saw the slide where it says older patients are the fastest growing population who may benefit from this curative option. We talked about it requires extensive planning, close collaboration, and commitment from the patients, their families, their support system, and the clinicians. The outcomes for donor transplant are rapidly improving because of better supportive care, more donor options, and optimization studies. And the most important point that you have to understand, and maybe talk to your primary hematologist or oncologist, is an early referral. Even though they might not think that you're a transplant candidate, please ask them to send you to a bigger center where you can get evaluated, because the eyes of the transplanter are different than the eyes of the general hematologist, oncologist. There may be some factors that we can modify, and you may be ready for transplant. So I feel like early evaluation by a transplant physician is very important in all these high-risk disease that we talked about. So this slide concludes. I just put this, I really find it funny. And I don't know if you're familiar, but a lot of people eat bone marrow as a delicacy. And I'm also one of them. I enjoy this dish, but I'm always like having shivers when I'm eating this. So I want to now open the for discussion, if you have any questions.
Yes, thank you, Dr. Nooruddin. We do have one question here. Do the sex chromosomes get changed after transplant from the opposite sex? And what about the blood type? Does that get changed after transplant?
Yes, we do look at these changes, and after transplant, we look at chimerism studies. So these are more sophisticated studies than the sex change, or they look at the lymphocytes of the donor and the recipient. So at day 30, we're looking at how many donor cells are there, how many recipient cells are left over. And over time, we do it at day 30, day 60, I believe day 90 or 100. And then we try to look at the percent of leftover cells from the donor, and the more chimerism, the more donor cells, we expect it to be 100%. And that's also, goes with the graft failure. If you have the graft failure, you'll have more donor lymphocytes. So yes, you do see a change in all these factors.
Thank you. And also, at what point should someone who's been diagnosed with one of the diseases, MDS, aplastic anemia, or PNH, begin to look for a donor or ask questions about looking for a donor?
That's a very good question, and I think I should have emphasized it a little bit more. If you think about the last point, the bone marrow transplant physicians go through an extra year of training to look for these things. So if you have the basic concept of MDS, or if you're familiar with PNH, or in the disease category, we talked about like the severe aplastic anemia, or we talked about the bone marrow failure PNH, and we talked about high risk MDS. So these are the patients, they should go to transplant as soon as they're diagnosed. So within the first few weeks. But also it doesn't harm, like if you are low risk, and because sometimes the disease will evolve, the low risk will become intermediate, can become high risk. So it doesn't harm to go see a transplant physician. It can be just as easy as one trip to the transplant center, and they can determine. Some patients, they can say that you're not a candidate now, but let's do this. Your heart function is borderline. Your heart function is like 40%. So let's go see a cardiologist in 6 months. If your heart function becomes 45, then we can take you to transplant. So these are the things that, but again, for high risk MDS, for severe aplastic anemia, for PNH with bone marrow failure, the sooner the better. So each disease and each severity, each indication is slightly different, but it's never too late to see a transplant physician. Not everyone will need transplant, but at least you will have an idea whether you will be a candidate or whether you will need it in future or not.
Thank you. We have another question. What happens to genetic mutations as a result of transplant?
So if you are like in aplastic anemia, or which is mainly the case in aplastic anemia, right? There are some causes of familial aplastic anemia, but also MDS familial causes are also been identified. So in that case, you have to be very selective about the donor. We mostly in all the transplant, we talked about matched sibling. That's the #1 choice for most allo transplant, except in these type of diseases, in genetic diseases, where you think or where you know that this disease is coming from the family. So when you're selecting a sibling or a haplo, you have to make sure they don't share the same bad genes, and hence you cannot take them as a donor. So identifying those genes and and making sure that the donor doesn't have those genes so that you don't get again transplanted with the bad genes is very important. But when you replace them with a healthy donor that don't have, so all the bad genes are gone.
Thank you. Next question is, can you get scleroderma-like syndrome after autologous transplant?
I'm sorry, what type of syndrome?
Scleroderma. I'm sorry, I mispronounced scleroderma.
We didn't talk about much about autologous stem cell transplant because the diseases that we were discussing today, MDS, allo, MDS, PNH, and aplastic anemia. But the auto is not intense and does not have a lot of side effects. This person is asking particularly about a disease called scleroderma, which is an autoimmune diseases. There are few case reports where when we do auto, we are focusing more because we're giving the patient's own cells, right? So here, the mechanism is not forming a new immune system, it's the patient's own immune system. The hitting mechanism here is the high dose chemotherapy. So the chemotherapy we use for autologous stem cell transplant is wiping your own blood system, but sometimes it can attack and cause autoimmune diseases. There are case reports where autologous transplant, patients can have autoimmune diseases. So yes, it's very rare, but it can happen. On the other hand, you can also assume that sometimes patients are more prone to some diseases, and it just manifested at an age where you got an autologous stem cell transplant and it manifested after 6 months or 1 year later. It's difficult to say whether the transplant caused it or you were bound to get it, but transplant definitely hits your immune system, any kind of transplant. So yes, you then become at increased risk of immune diseases.
Thank you. Why would having prior solid tumor cancers prevent someone from having a transplant?
That's a very good question. When we talk about solid tumors, the main thing is if you had a history of solid tumor 20 years ago, it doesn't exclude you, which means you're in remission. But if you had a history within the last 2 or 3 years, there are different cancers which define remission differently. But let's say if you had a breast cancer last year and now you have MDS, so that would increase your risk because you had cancer chemotherapy, and then the risk of when you're doing the transplant where you're doing intensive chemotherapy and you're giving high bombing doses of immunosuppressive medication for the whole mechanism of transplant, the breast cancer may come back because you've suppressed the immunity, or your original cancer may come back. So you don't want to try to treat one disease and have the other cancer come back. But if you're in remission for 5 years, 3 to 5 years, we can consider. A lot of patients, older patients, and I've seen that a couple of times, like prostate cancer, which is very common in men, right? And a lot of patients have these low-grade prostate cancer. Again, we have to discuss the risk. It's not 100% exclusion, but it gives you higher points. It just adds to one more point, and one more point adds to one more morbidity, more complications. So we discuss the risk of, there are some cancers which we can, take a little bit lightly and are not excluded, but there are some cancers or immediate history, preceding history of cancer is taken very seriously because you don't want the cancer to come back during or post-transplant.
Thank you. And our last question, can you transplant a diffuse large B-cell lymphoma patient if they are not in remission with their last chemo?
This is a difficult question. This is a question where there's very limited data, and unfortunately, the outcomes are not good. So diffuse large cell lymphoma is the most common transplant that we use for diffuse large B cell is the autologous stem cell transplant. But remember, when we were discussing the pre-transplant, I think the most important cause in DLBCL or diffuse large B-cell lymphoma is the pre-treatment disease control. So ideally, you should not have any disease. Your pet should be clean. Or you should prove that before PET, you were treated and you responded to chemo a little bit, but it didn't take it away completely. So we can do auto and prove that, yes, the patient received chemo and his disease is sensitive. And when we are going to give this bombarding dose of high dose chemo, the disease will respond further. The outcomes are poor if you have a preceding disease. But the promising part is now, instead of, because you can't do auto, but for the last, like 2017, there's this new cellular therapy called CAR T cells, has been approved for diffuse large B-cell lymphoma for patients whose disease is not controlled prior to auto. So instead of auto, they go for CAR T cell treatment, and that's where this treatment is indicated. For some reason, if you are not a candidate for CAR T cell treatment and still want to take the risk of auto, very few centers will do it. And but the outcomes have not been that great. So the best option for these patients are go for a clinical trial to try an option that will decrease their disease to show the term what we call chemosensitivity, or go for CAR T cell.
Thank you, Dr. Nooruddin, and thank you for sharing your time and expertise with us today.
Thank you, Alice.
Thank you. If you would like to watch this session again at a later time, it will be available on the conference platform by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. We will try to correct the audio issues before we post it. So we'll let registrants know when the clear version of the program is posted. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF hotline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. There is still time to visit the exhibit booths, and the support groups will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family, as we have for the past 38 years. This concludes the session.